So again, presentations all get submitted in the drop-down box. Everybody has to present part of the project during class as a group. And so you can, however you guys want to split it up, that's fine. As long as everybody does part of the presentation. And then, of course, in week 11, we have our HESI. And then in week 12, we'll have our final class meeting. So does anybody have any questions about the project or anything about anything, I guess would be my question. We're going to be quiet tonight. Okay. All right. So for tonight, we are going to talk about nursing theory. Okay. So in your Success in Practical Nursing book, this is chapter 13. In your concepts book, it is concept 47. I always want to say chapter 47. It's concept 47 in your concepts book. And then in your nursing delegation and management of care book, it is going to be chapter 18. So it's all about research and theory and evidence-based practice. So those are going to be the topics for tonight. After the lecture, we have a case study to do. So we'll work on the case study together. And if we have time, which we should, I do have some practice questions that we can work on as well. So we will start with the PowerPoint presentation. So I will share my screen. All right, everybody can see the PowerPoint. So we look at nursing theory, all right, and so there's numerous nursing theories for that, that have been developed for nursing. There's a really good website. It's called nursingtheory.org that you can look and you can see all of the nursing theories that are up there. We are not covering all of the nursing theorists. There's only a select few that we are going to talk about. So again, oops. So there are numerous theories that have been developed for nursing. Some of them are even the basis for curriculum development. So when we're, looking at developing curriculums for nursing programs and other educational sessions, a lot of them are based off of a nursing theory, or they use nursing theories as a foundation for that course. They also are a basis for research on the effectiveness of nursing care. Okay. And so the following or these three concepts are important to nursing, right? The person or is the recipient of care, or clients or patients, whatever you want to call them, right? Health, which is the goal of nursing, right? Goal is to restore health or get them back to as close to a previous level of functioning as possible. And then, of course, the environment where nursing care takes place. And we know that nursing care can take place in numerous types of environments, in the hospital, in a long-term care, at home, rehab facilities, right, clinics, urgent cares, all of those wonderful places. So we need to understand nursing theory. If anybody does plan on going back, or when you decide to go back to get your RN, you are going to study theories a little bit more in depth. Most BSN programs most BSN programs have some sort of a nursing theory course. So you'll learn a little bit more about the nursing theorists and the different types of theories. But again, a lot of them are foundations for education as well as clinical practice. So that is why we cover them. Everybody should have heard of this one, the first one, which is good old Florence Nightingale. So she was known as the first nursing theorist. So in 1860, when Florence worked with the wounded soldiers during the Crimean War, she collected a lot of data because she at first was she was a statistician as well. So she was the first one to collect data and use evidence to make clinical decisions. And she was the first to emphasize the environment, ventilation, warmth, noise, light, and cleanliness, right? Keeping them clean, preventing the spread of infection and disease from one person to another, right? Fresh air, ventilation, light, all of those wonderful things. She felt strongly that environmental issues influence the course of illness, and hence she became the first nursing theorist, right? And she has her own theory out there, and a lot of what we do, right, is based off of what she has taught us. Abraham Maslow was not a nurse. He was actually a psychologist, but we use Maslow's theory a lot in nursing, right? It's a framework for education. It's also, right, how we develop some of our, our nursing interventions or nursing diagnoses based off of human needs. His theory states that there are certain internal, external, physical, and psychological needs that are common to all people, right? So if you remember what his hierarchy looks like, right? Those basic needs are at the bottom of his hierarchy. Oxygenation, trying to think what else. Food, safety, rest and comfort, right? Those are all basic human needs. And so again, those common needs are arranged in a hierarchy, and we try to move up the hierarchy, right, by meeting those needs. Unmet needs create tension, which motivates the person to react to meet the need, right? So if I'm not breathing very well, or I'm not able to perfuse very well, right, that's going to create tension. It's going to motivate a person to be able to either, get help or, improve their oxygenation. Same thing with food and water, right? You don't have ready access to food and water, right? That's going to create tension. It's going to motivate you to find food and water. Once those needs are met, then the person's no longer aware of the needs and the need no longer motivates them, right? So if I have, access to food and water, and I'm safe and I'm, able to rest and I'm, all my basic needs are met, then I can start to move up that hierarchy. The dominant needs that matter to a person can vary in life. Okay, so some of the dominant needs that maybe were more important to you when you were younger aren't as important as you get older, and vice versa, right? Some of the needs that weren't so important when you were younger may be more important to you as you get older. But again, it's those unmet needs that create tension, and it's going to motivate that person to meet those needs. So Dorothea Orem. She has her theory is her self-care deficit theory. Okay. It is a general theory. It has three sub-theories. So we have self-care deficit, and we have the nursing system. So self-care, this is a goal that is directed towards a safer environment for life, health, and well-being. So ideally, people have, or they learn to respond to health cues in themselves or within the environment, as a way to maintain personal health, right? So we can respond to changes within ourselves, right? To, make necessary adjustments to maintain health. A self-care deficit, the personal care doesn't meet the therapeutic self-care demands. Well, so the person is not recognizing, or they may not know what to do in regard to personal health situations. So I get sick, I go to the doctor. Anybody that comes into our care, right, has a self-care deficit, right? They need assistance because they are not able to care for themselves. And then we have the nursing system. And nurses empower clients through their interpersonal relationship to help meet their self-care demands. Okay. So we respond to to people, their total or their care needs totally, partially, or sometimes in a supportive role. But Orm's theory is concerned with growth and development needs as well as the physiological and the psychological needs. So when we look at when we are doing our data collection or assessment on our patients, right? We are identifying specific self-care deficits, right? And you've written a care plan or a nursing diagnosis, right? You know that there are self-care deficit nursing diagnoses that are there. And so then we choose the interventions, right, to that will have the desired outcomes for our clients. We have Madeline Leninger. Madeline Leninger had her cultural care theory. And so she had an interest in cultural care and how nursing responds to people of different cultures. So she recognized that there was a link to understanding care based on cultural background, right? And we've talked about culture and spirituality and how important that is, right, when we are caring for our clients. And so when developing her cultural care theory, she identified that there's two kinds of care in every culture. We have the generic, which is like home remedies that used in care. So a lot of people use everybody probably uses home remedies, right? Get a cold, you have your allergies, and what do, right? So depending, it's not always culturally based, but you may get some allergy medicine, right? You may take some ibuprofen. You may have some tea, right? Whatever, your particular, maybe things, something that you grew up with that works. And then we have the professional care that's provided by people who are specifically trained to provide care. So generic is the home and professional is, by professionals that are trained to provide care. She also proposed three modes that guide nursing decisions. When providing care. So the first one is cultural care preservation or maintenance. The second one is, give me one second, cultural care accommodation or negotiation, and then cultural care repattering or restructuring. So again, this is a basis, right, for providing that culturally competent care. And then we have Hildegard Peplau. She had her interpersonal relations theory, which is the basis for developing our therapeutic relationship with our clients. And so she said that there's certain parameters, right? And we know that is a major part of treatment, right? We have to be able to develop that therapeutic relationship with our client. And we do that in a variety of ways, even with therapeutic communication. There are four stages to her, or four phases to her theory. The first one is orientation. Okay, so the client seeks assistance because of a felt need. They've identified that there's a problem, and the nurse works with the client to help him or, help them recognize that, what the problem is. Identification, the client now understands the situation and is going to respond to the nurse who is helping them. Exploitation, this is where the patient or the client begins to depend on the nurse, and will accept and use the help that is offered. And then during the resolution phase, this is where the dependent behavior that developed is given up because the relationship is now ending. And so whether it's because, they're being discharged, they're being transferred, something along those lines. Then we have Rosenstock's health belief theory, that tries to explain why or why not a person will take action to prevent or detect illness. And so, according to Rosenstock's theory, for one, perceptions vary. They may have no basis in reality. And so, that could be because, they don't recognize the signs, or something along those lines, or, they don't, that's another one. Um, they didn't feel like they needed healthcare or for whatever reason. Um, with and then beliefs are connected to existing barriers. Okay, so when we look at this part of it, um, why aren't they seeking healthcare? Is it because it's too expensive and they don't have insurance? Is it inconvenient, right? Their doctor's office is open from 9 to 5, but they work from 9 to 5, right? It's not convenient. Or in some cases, if they think that the procedure or the process is going to be painful. And pain is a big thing, right? A lot of people seek healthcare for pain, but other people are frightened of certain things, right? Because they are afraid that it may be painful. And then a cue to action is seen as necessary. All right. So whether they will or won't take action. And when we look at a cue to action is seen as necessary. So the cue for the client, um, so whether it's pain, like I said, pain is often a big reason why people seek healthcare because generally nobody wants to be in pain, right? Or it could be a news story, or it could be a commercial on TV. And so they're getting a little bit more, I don't know what the word is, um, proactive approach, maybe would be a good word, right? You see commercials on TV now talking about hypertension and other disease processes. And I'm not talking about the medication commercials where everybody is like, try this new medication, but some of them that are just out there to raise awareness, right? And so the more information people have, right, sometimes that may, cause them to think, oh, wait, maybe this can happen to me. Maybe I should go to the doctor and just get checked out. Or it could be sometimes something as simple as, a call from the doctor's office or a postcard from the doctor's office that says, hey, we haven't seen you in a while. All right, maybe it's time you come in for a checkup. So again, this theory also, when we're using the nursing process for health promotion, okay, this can be helpful as well, right? So when we look at, promoting those annual wellness checkups or, the vaccines, even wellness classes, that is how it kind of would fit into the nursing process. Um, then we have two more. So we have Sister Calista Roy. She developed her adaptation model. And so she describes the client as a holistic adaptive system, right? So holistic adaptive system. And she said that both internal and external stimuli affect the system, which we understand, right? So the following types of stimuli. So we have focal stimuli. That's something that is direct. So again, that patient that experiencing pain. We have a contextual, right? Which is other factors that affect the focal stimuli. So you go in because you sprained your wrist, right? And you're in pain. So what do? You go to the doctor. And what's the doctor going to do? They're going to move your wrist around because they want to see what's going on, right? Which can potentially cause even more pain. And then residual. That's the internal and external factors that may not always be evident. So maybe they have sprained their wrist before or broken their wrist before, and they have that memory of a previous pain, and maybe that wasn't such a good experience. Okay, so that would be the residual. We also have our coping methods. Okay. And so coping mechanisms or coping methods, these are known as regulator or cognator. So when we look at regulator, these refer to the internal effects that take place in response to what is happening internally. Okay. So people that are in acute pain, all right, generally will have activation of the sympathetic nervous system. All right. And so, what is involved? So, tell me what happens to internally, what happens to you when your sympathetic nervous system is activated? What are some of the changes that occur?
Like the
Hyperventilation,
Say that one more time. I'm sorry.
hyperventilation,
Hyperventilation. Okay. What else? So, my respirations are going to go up. What else is going to happen? Think about it.
tachycardia.
Tachycardia. Thank you. What else?
You're gonna get restless.
Okay. Restless. So think about it. So let's say you're driving down the road, okay, and a squirrel runs in front of your car, and you have to slam on the brakes to prevent the squirrel. Well, how does that make you feel? Yeah, fight or flight, exactly, Diamonds. What else? Brittany, what else happens?
Like the dilated pupils.
Okay, dilated pupils. What else?
The temperature of your body change.
Sometimes, not all the time, but sometimes. Depends on the situation. Anxiety. Yep. So my blood pressure is going to go up. My respiratory rate is going to go up. My heart rate's going to go up. My pupils are going to dilate. My GI tract, my GE tract, right? Those things slow down. But we have, right? So that's a combination. It's combination of my nervous system. It's combination of my endocrine system, the chemical processes, right? Because those neurotransmitters, right? Epinephrine and norepinephrine is those, what's going to cause those fight or flight, right? So think about it, right? So, and I'm not saying that, everything is going to be fight or flight. I'm just saying that these are some of the changes that are going to occur that would could potentially happen in an emergency situation. So just think about the things that would potentially see. So those would be the regulator subsystems. Okay, and so oops. So then we have the cognator. All right. And the cognator subsystem, this is the learning process, the processing, the judging, trying to think of what else, the emotion that the client uses, um, to cope with what has happened. All right. So this is more, again, it's more of your, what is going on within your head? How are we handling the situation? How are we coping with that situation? Does that make sense? Do you understand the difference between the two? Um, and so, the different things can happen just based on, whatever the situation is. And then we have Jean Watson. So Jean Watson has her theory of human care. Okay. And so this theory says that health is harmony between the body, mind, and spirit, right? Sounds familiar, right? That holistic care. It also involves self-perception and how the self is experienced. Illness is a lack of harmony between the self and the soul. So the nursing role is a caring process to help regain that harmony in the health. And so through caring, the client develops self-knowledge as well as self-learning. And those allow the clients to solve problems, to grow. And even in that process, the nurse also may grow as well. So her theory is very prevalent in a lot of places. Um, And then, like I said, there are so many more nursing theorists out there that if you become interested in nursing theories, they're just fascinating and interesting. A lot of them you probably, as read through nursing theories, you would probably recognize them. They kind of tell us, you know, um, it's a basis for a lot of the things that we teach you in nursing school. How we do things, why we do things. A lot of these things, even though we're not telling you, hey, this is based on this person's theory, but a lot of what we do is based off of nursing theory. Which brings us into nursing research. Okay. So, in order for them to develop their nursing theories, right, they have to do research. All right. Because they can't just, make a theory without doing research. And so, in any subject, it's not just nursing or any profession, I should say, not just nursing, knowledge, existing knowledge and developing new knowledge is based off of observation, experimentation. And so again, this goes all the way back to Florence Nightingale, right? She did her research, she did her statistics, and she, realized what was going on and she put into play her theory, which actually was very effective in helping to decrease the morbidity and the mortality of the soldiers during the Crimean War. So, nursing research also has improved nursing existing knowledge. It's generated new knowledge, right, that influence our nursing practice. They also identify specific nursing interventions that are proven effective, right? Not just merely based on tradition. So it's not, we're doing this because we've always done it, right? There's usually some sort of proven effectiveness, right? Like, why do we turn and reposition our patients every 2 hours, right? Or why we use sterile process for some procedures and not for others. Why do we do Foley catheter care, right? Why do we do chlorhexidine baths, right? So all of those things, there is some sort of, they've been proven effective. They're not necessarily based on tradition, but there's some evidence to their effectiveness. It also provides evidence to support the quality and the cost effectiveness of what nurses do. And it generates knowledge for clinical practice, nursing education, as well as the delivery of nursing services. And nurses at all levels, doesn't matter, LPN, RN, BSN, MSN, doctorate, everyone is encouraged to participate and promote nursing research in varying degrees. Okay. There are two main types of research studies that are done in nursing. We have quantitative and qualitative. So quantitative research studies are objective studies. Tried to make that all one word, one word. So your quantitative research studies, again, these are objective research studies where a variable is the event that the researcher is trying to measure. And there are two types of variables. And so one variable is the group that receives the intervention. The other variable is the group that does not receive the intervention. And then we collect the numeric data and then we measure using statistics, and there's a nice long process there. But again, we're collecting data. Okay, so it's very objective. So example, so let's say we are testing a new hypertensive medication. Okay. So, the pharmaceutical company is like, hey, I've got this new medication. I want to test it out. We get through the, approval process. So we have two groups of people. Group A is going to receive the new medication that we are trying to, or that we're developing, that we're studying. And then the second group is going to be people who are maybe just that are using the current treatment. Okay, so they're getting two different sets of medication. And then we're going to give them the medication. We're going to collect data on the results. Okay, so is it working? Is it not working? The randomized control trial, that is the recommended type of quantitative research. So again, we want to do that randomized control trial. Again, that and all that is we got the two different variables, one group receiving the intervention, the other group is not. A qualitative research study is what we would consider a subjective study. Okay, so objective, just like when you're collecting objective data or subjective data from your clients, same kind of thing. Objective for quantitative is quantifiable. With qualitative, it's very subjective. So data is collected by interviews. It is a study, a narrative description of the lived experiences of individuals. So for example, here, let's say we got a group of people who have chronic pain. All right. And so we're going to do a series of interviews and we are going to have them describe their experiences with chronic pain. And of course, there's going to be a series of questions that each client or each person is going to be asked. But we're getting lived experiences. So this is what makes this subjective, right? Not really quantifiable, right? We don't have any hardcore data. We're just getting information. Phenomenology is an occurrence or a circumstance that a researcher studies. So here, the example here is a case study examining the lived experiences of high school students who are both gifted and diagnosed with ADHD, right? So they're going to get a group of, high school children or high school kids that are both gifted and have ADHD, and we are going to conduct an interview and get that information about what it is like for them. So again, quantitative is objective using the randomized control trial. My gosh, can't even say the word randomized control trial. And then we have our qualitative research study. And this is going to be subjective. So we look back at evidence-based practice. Okay, so Dr. Archie Cochrane, he was a British epidemiologist. He challenged the public to pay only for medical care that was proven to be effective. And he advocated the use of those randomized control trials as a means of reliably informing healthcare practice. So again, we, think about pharmacology, right? When you, learned about the drug approval process, right? We don't just make a drug and just release it out into the public, right? It has to go through a number of steps before it gets out to the public. And so same thing, we want to go through and we want to see if the medication, the interventions, whatever it is, are effective, the treatments, if to make sure that they are effective, right? Not just like, oh, we're going to try this, see if this works. And he established, or I don't think he didn't establish it, but the Cochrane collaboration that was established after he passed away was established to prepare and promote the accessibility of Cochrane reviews, which are a collection of evidence-based healthcare interventions that are obtained by systematic reviews of research. And so what does that mean? So anytime we are looking at interventions, regardless of the intervention, we're going to do a systematic review of research. And so we'll talk about this in a little bit more, but basically you're going to look and whatever your topic that you want to research is, you are going to take that topic, and you're going to, um, what's the word I'm looking for? You're going to enter it in, and then you're going to go and you're going to find a whole bunch of articles that are, research that is related to what you are trying to find, and then you're going to read all of them and you're going to look at all of them, and you're going to get a bunch of information from those. So that's what a systematic review of research is you're going to find a whole bunch of research articles, you're going to read through them, you're going to look at their findings, whether the finding, whether the intervention was effective or ineffective, and you're going to, implement those into your practice. That's what a systematic review of research is. Back in 1999, I know this was a long time ago, but this was a landmark study. So the Institute of Medicine issued the report to Air is Human. What is it? To Air is Human, building a safer healthcare system. And so when we look at this study, so like I said, this was a landmark study. And so it don't remember the exact numbers. Like I've read this study. Um and so it was actually, like I said, it's a landmark study. It said, I can't remember what the actual cost was, but it basically outlined the number of medical errors, okay, and their effects that they had. So it was in the thousands. I mean, it was significant. It was very significant. And so it wasn't just medical, like it wasn't just medication errors, although medication errors were at the top, but it was somewhere between, like it was like up to 98,000 people die each year in the US as a result of medical errors. And like I said, it's not just medication errors, but medication errors were pretty significant. But these are also things like seeing or wrong site surgeries, and other issues that, take place within healthcare. And so it called for a bunch of system-wide changes. Um, and then in 2001, the Institute of Medicine issued Crossing the Quality Chasm, a new health system for the 21st century. And this called for consistent, high quality healthcare for all people. And so included in this was patients should receive care based on the best available scientific knowledge. Okay, so we're just pushing that evidence-based practice. They did a follow-up to the IOM study, and I don't remember what year it was. I can't remember if it was like 10 or 20 years later. Um, but they did do a follow-up to the 1999 study. Um, oh, this was one of them, but then there was another one that they did, but there wasn't a significant impact. Okay. So when we think of some of the changes that they put into place, they focused a lot on safer medication administration. They implemented things like I can't remember exactly what it's called, but like a surgery timeout. So like if you're going in for a surgery or for a procedure or something along those lines, there's a timeout process, okay, where everybody stops, they identify the patient, the allergies, and of course, what the procedure or what the surgery is. Um, and so these are all ways that we um, just strive to make sure that we are not making, or avoiding errors as much as possible. And so we have known, if you've watched the news, even TikTok, Facebook, any of those, You can see that there are still significant issues within the healthcare system. Um, and so, this could be wrong site, wrong patient surgeries, even, retained foreign objects. I actually had one of the CNAs that I worked with. This was a long time ago, but one of the CNAs that I worked with, she had gastric bypass surgery. Um, and I don't remember how like soon after the surgery but she always kept complaining of abdominal pain, and they just were like relating it to the gastric bypass, like it's going to go away, you'll get better. And um eventually somebody finally listened to her and they did a CT scan, and somebody had left a clamp. When they did the gastric bypass, they had left a clamp inside. And so she had to have surgery again to, right, remove the clamp. Um, there's been, others, we've had people that have had unnecessary surgeries. Um, we've had people that are still having, there's still mix up with patients and, not having the correct surgeries. Of course, a lot of what we hear about too is the medication errors. And we know that there's been some significant medication errors that have occurred. Um, and so, again, it's about being safe and providing safe, effective care for our clients. And again, it's a lot of our safety interventions have been put in place to try to prevent these from occurring. Um, when we look more into evidence-based care, and I think I've said this previously, during the last 2 decades, insurance companies began to pay for healthcare practices only if their effectiveness is supported by scientific evidence. Okay. So we're not just doing procedures, we're not just providing care because we think it will help. Okay. We are providing care that is supported by scientific evidence. And then during the last decade, so within the last 10 years, hospitals are denied payment when complications in a Medicare client develop if evidence-based guidelines are not followed. Okay, so this is where we've talked about the central or the catheter-associated urinary tract infections, the fall with injuries, the development of pressure areas, the central line infections, right? So documentation is so important in these situations, right? Because we know in certain situations, right, even with proper guidelines, people can still have issues, right? They can still develop infections, they can still fall, they can still develop a pressure area. But this is where your documentation is super important, that we're documenting all of those evidence-based interventions in order to make sure that our clients are safe. Clients and families as well are seeking the latest evidence on websites about the most effective treatment for illnesses and diseases. And so, yes, not everybody has access to computers and the internet, but a lot more people are starting to look up, right? What are the best treatment options for whatever disease, whatever. And so, we have to be able to take that into consideration as well. A lot of our clients are a lot more informed about their disease processes, and the treatments that are available. And one of the big things that we can ensure is when we're talking to our clients is to make sure that they are using the correct sites, right? We want to make sure that they are truly finding the best evidence-based interventions that are effective. So how do we determine, or how best evidence for practice guidelines is determined? Okay, so there is a very complex, rigorous process, okay, to, determining what the best evidence, for practice is. So the first thing we want to do is develop the question. What is it that we are trying to investigate? Okay, so you're going to formulate that in a very objective, a very concise manner. And then you're going to use professional resources. All right, so when I say professional resources, you're going to, you can go to your online library. And so you have things like PubMed, you have EBSCO. What else do we have? We have CINAHL. We talked about the Cochrane Review, so you can do the Cochrane Review. There's also the AHRQ, which is the Agency for Healthcare Research and Quality. And we also have things like the Joanna Briggs Institute. Forget the other one. There's another one I was going to say, and I can't remember. But you're gonna, go into the, and do a database search. All right. And you're going to find research studies that are related to whatever your question is. And then you're going to get all those articles together. And then either an expert or a panel of experts is going to look at all those research studies and do what's called a systematic review. So basically, let's say you have 10 research studies on I'm just going to say fall prevention. All right. So you've collected 10 research studies on fall prevention. And so now you are going to take those 10 research studies, you're going to present them to an expert or a panel of experts, and they are going to go through each one of those and do a systematic review. Okay. And then they're going to write a summary of the results of all of those studies. And then from the results of that review, they are going to determine the guidelines for whatever it is that you are looking for. And then they're going to use critical thinking skills. You're going to take the gathered evidence combined with clinical experience, as well as client preferences and values for use in a clinical situation. So again, whatever the situation is, like I said, I just used falls because that was something that's always an issue. So, you can go into one of those databases and put in, fall prevention in the elderly or in a hospital setting, whatever it is. You're going to get your articles, and then they're going to review the articles, and they're going to see what are the fall prevention practices that have been utilized to help prevent falls. And then you're going to take all that evidence, you're going to, your experience with the patient's preferences as well, and then you are going to implement those interventions. So again, the elements of evidence-based practice are the best research evidence, the clinical expertise of the nurse, and the client's preferences. So we are going to incorporate all of those into those interventions that we are going to implement. So we look at the nurse's role, okay? Like I said, doesn't matter what level of nursing you are in, LPN, RN, BSN, MSN, doctorate, everybody can play a role in nursing research and developing evidence-based practice. Okay. And it's called the spirit of inquiry. All right. So a nurse that has a spirit of inquiry is one who's going to raise questions. They're going to challenge the status quo and seek more creative approaches to problems. So we have nurses with research doctorate. Those are your PhDs, okay? They design and implement research studies. They publish their findings. Nurses with a practice doctorate. So I'm in school for my practice doctorate, which is a DNP, or a Doctor of Nursing Practice. They review present research and they formulate evidence-based protocols. So again, can use fall prevention. I can do a whole bunch of research and look at, all of our research articles on fall prevention, and take that, right, and then formulate protocols for fall prevention. At the master's level, they can formulate questions, evaluate the effect of evidence-based solutions. With bachelor's degrees, they also can formulate questions. They can critique published research, and they can use evidence as solution to nursing problems. Associate degrees, they challenge the status quo, they question assumptions, they offer new insights into, to improve the quality of care. And then practical nurses, they also question the basis for nursing actions by considering research evidence, tradition, and client preferences. You guys are going out with fresh eyes, right? You're graduating from nursing school. You're going out with fresh eyes. You may be able to recognize things that need to be changed, things that could be done better, or things that could be fixed, right? So you as practical nurses can play a big part in making things better, right, for everybody else. So again, you can question the basis for nursing actions by considering research, evidence, tradition, client preferences. You can review current articles in professional sources, even as part of a student learning process. I don't know, like you can go into your libraries. A lot of the libraries will have hard copies of some of the nursing publications. Otherwise, you can use the online library, right? And you can do a search. You can support nursing interventions on care plans and in practice with evidence-based nursing practices. And as students and graduates, you need to follow protocols and procedures for nursing interventions, right? Wherever you are practicing. And I talked about the spirit of inquiry, right? It's raising questions, it's challenging the status quo, it's seeking to create approaches to problems. And like I said, you guys are going out with fresh eyes, with new eyes. You can see some of the things that are going well. You may even recognize things that could be improved upon. And so that is the purpose. And nobody is going to fault you for doing research and presenting your findings, especially if you find something that needs to be changed or you find a way to do something a little bit better. All right, so let's do a review. All right, so what are the three concepts when we related to theory? What are the three concepts that are important to nursing? Mentioned them at the beginning. What are the three concepts that are important to nursing? Not the theories themselves. What are the concepts within the theories?
Clinical reasoning.
The person, health.
Health and environment.
Yep. So the three concepts that are important for nursing is the person, health, and the environment. All right. So then we had Florence Nightingale. She was the wonderful first nursing theory. And then we had Abraham Maslow. So tell me how Maslow's hierarchy works.
It's to categorize patient needs based on prioritization, like physiology. I can't pronounce the word. Safety. I think it's like self-esteem, something like
Yep,
that.
absolutely. Yeah. So it's a prioritization of patients' needs. That's a good one. I like that. Very good. Right. So they're, again, they're arranged in that hierarchy. So yes, your physiological needs are at the bottom, right? Then safety, love and belonging, self-esteem, and of course, we all try to reach that highest level of self-actualization. Good job. And so remember that the unmet needs are going to create tension, right? That's going to motivate you to try to meet those needs. And then once those needs are met, right, it's no longer a motivator, right? And we're always trying to move up that hierarchy. Um, our dominant needs that matter can vary, right, throughout our lifespan. Um, what else? With Dorothea Orem, right? She had her self-care deficit theory. The three sub-theories were self-care, self-care deficit, and the nursing system. Leninger had her cultural care theory. Peplau had her interpersonal relations theory, which is the basis for developing that therapeutic relationship with our clients. Rosenstock's health belief theory tries to explain why a person will or won't take action to prevent or detect illness. And then we had Sister Callista Roy's adaptation model, which, she described the client as a holistic adaptive system. And then, of course, we had Watson's theory of human care. Which type of research study uses variables and is objective?
Quantitative research.
Very good. Quantitative. And
What?
go ahead.
No, just repeating the words so I can
Oh, quantitative,
Quan, quan,
quantitative.
quantitative.
Yeah. And what is a qualitative research study?
The one that talk from the living experience from the
Very good. It's a subjective, right? It's a lived experience. Good job. Let's see what else. All right. What are the three main elements of evidence-based practice?
I have here is best research evidence, clinical expertise, and client preference.
Very good. So the three main elements of your evidence-based practice is your best research evidence, your nurse's clinical expertise, and your client preferences. Good job. All right. All right. So we are finished with that. We're gonna do our case study next. So we'll have a case study, but I will give you guys a break. So be back at 6:40. All right. I'm going to share my screen. We have a nice little case study. All right. So we have Mr. James Walker. He is an 82-year-old male admitted to the med surg unit with community-acquired pneumonia and dehydration. He has a history of type 2 diabetes mellitus, hypertension, chronic kidney disease stage 3, and frequent hospital readmissions. Mr. Walker lives alone. He has limited financial resources, and he reports difficulty paying for medications and often skips doses to save money. His vital signs, he has a temperature of 101.8. He has a heart rate of 108. He has a respiratory rate of 26. He has a blood pressure of 146 over 88, and he has O2 sats of 89% on room air. So, what are some issues here?
Low O2.
Okay, low O2.
High respiratory rate and heart
Yep.
rate.
High heart rate, high respiratory rate.
The blood
He's
pressure is
got
a little elevated too.
blood pressure is elevated.
10% of fever.
Yep, and he's
Fever.
got a fever. And see, remember, he's got the history of hypertension, right? But he skips doses to save money. So it doesn't say which medications, right? All right. So current orders. We have oxygen at 2 liters per minute via nasal cannula. We are having IV of normal saline at 75 mLs per hour. We have IV antibiotics every 8 hours. We are going to do glucose monitoring, AC and HS. What is AC and HS?
Morning and night. I think no, before the meal and after meal.
Before meal, after meal.
No, this is before meals. And what is this?
Hmm.
Hi, that's
At night.
At
There
bed.
you go. Yep. So AC is before meals, and then HS is at bedtime. Um, After meals would be what? Anybody know what the abbreviation for after meals is? PC, yes.
PC.
Very
Oh,
good.
oh,
Yep.
sorry.
No worries. So AC is before, PC is after, and HS is at bedtime. We're also going to put them on fall precautions, and we are going to do a CBC and a CMP. So just curious, what is the difference between a CBC and a CMP?
The CBC is like your blood count and platelets and hemoglobin levels. Like it'll give you a good idea if you have an infection or anything.
Okay.
And
CMP is the metabolism and organ function.
Very good. So yeah, so your CBC is going to measure it's your blood count, right? So your blood cells, so your red blood cells, your white blood cells, your platelets, your hemoglobin and hematocrit. And then a CMP, which is a comprehensive metabolic panel, that is going to look at your kidney function, your liver function, your electrolytes and fluid balance. Also going to look at your blood sugar, and then, other minerals like calcium and things like that. Good job. All right, so this is what is going on the unit. All right, so the med surg floor is currently short-staffed due to several nurses calling out sick. The charge nurse assigns the LPN 4 clients, including Mr. Walker. During the shift, a medication scanner is unavailable because the battery is dead. The dietary services accidentally delivers a regular diet instead of a diabetic diet. Environmental services reports a delay in cleaning rooms due to understaffing. And Mr. Walker states he may refuse one of his medications because he can't afford it after discharge. So, nursing observations. LPN notices that Mr. Walker attempts to walk to the bathroom without assistance. The IV tubing is not labeled with the date and time. The client coughs frequently and appears more short of breath. And another nurse states, "We're too busy to worry about small details today." So just with this information between what's going on, let's start with what's going on with the unit. What are some issues here?
Short staff.
Okay, short staff.
The scanner's not working.
The scanner is not
His
working.
battery is dead.
The
Like
IV
him,
He got the
dated.
wrong food.
Yep. He's got the wrong food, or the wrong diet was delivered. Um, Environmental services, I mean, that's an issue too, but when we look
yeah,
at patient safety, right, those are some of the big things. What are the issues here?
He's trying to walk without help.
He's walking without help, and we already know he's fall risk, right?
Right.
Okay, what else?
IV
Short of
tube is
breath.
not
you
labeled
don't
with
know
the
how
date
old
and
it is.
time.
Mm.
Yep, the IV tubing is not labeled with the date and time. Why is that an issue?
You don't know how old it is or when it
Don't
was
know
put
how old it
in.
is. Don't know what medication it was used for, right? Was it used for
Mhm.
the antibiotics? Is it just for the normal saline? Then how old is it? How long has it been hanging? What else?
The client coughs frequently and appears short of breath.
Okay. And then this is like the worst statement I've seen on here, right?
Yeah.
We're too busy to worry about small details today. So I'm trying to figure out what the small details are, right? So depending on, with this right here, okay, depending on what they're given, all right. So if it's normal saline and it's continuous, right? Depending on hospital protocol, really this doesn't need to be changed every day, right? It can run, I think it's like 72 or 96, 70, 96 hours, something around those lines, okay? If it's a continuous infusion. Okay. But again, we don't know, right? How long it's been hanging there. And what's going on. And so it really just kind of depends. So some of the safety risks we talked about, right? So we talked about the medication scanner is dead. We got the wrong tray. Okay. Environmental services isn't cleaning. And he's going to refuse his medications because he can't refuse them. Okay. We identified that he is walking without assistance, that the IV tubing is not labeled. He's coughing more frequently and appears more short of breath. And this I have no words for. Okay. Um, so of everything that is going on with him, what should we prioritize?
What do you mean? Which one is more important?
Yep, which one is more important?
I think the
Um,
coughing is short of breath.
Okay,
yeah.
right? Follow your ABCs, right? So short of breath, right? That's
Mhm.
going to be my priority. Why is proper medication scanning important?
So we don't give the wrong medication to the wrong patient.
So we don't give the wrong medication to the wrong patient, right? Think of your rights of medication administration, right? Or too much, or too
Too
little,
much.
or not at the right time, or maybe even the wrong medication, right?
Mhm.
So Lots of reasons. Also, too, who's used the scanners? Has anybody ever used the scanners?
I
Yeah.
have. Hmm.
Okay. What does Katrina, I am so sorry. I just noticed on your login that your last name isn't there. Can you add it? Katrina, can you add your last name to your login? I
You
just
said add
noticed.
my last name?
Yeah, I just noticed that your name isn't correct. I'm sorry.
Okay. I'm doing it now.
Thank you. So yeah, so um there's lots of different reasons. What about the diet orders? What about giving him the wrong diet? How can that affect him?
He's a
Raises
diabetic, so
glucose.
yeah.
Yep, he is. So they gave him a regular diet instead of the diabetic diet, right? And
Mhm.
so he's got diabetes, right? So we're worried about those glucose levels. What about the financial concerns? How can that impact client outcomes and readmissions?
It caused them to have to come back multiple times.
Mhm.
Okay. It causes them to come back multiple times. And what happens with readmissions? It
Like, is
didn't
it
change, Katrina. Go ahead. Somebody was talking. Go ahead, Kizzy.
is it more or less like or so they keep trying to treat the same thing like a revolving door in a sense?
Insurances don't pay for readmissions
So
if it's
they'll
the same
pay
thing.
for readmissions. Katrina, do you need me to do it? They'll pay for readmissions, but what are they going to do?
You're still gonna put they're gonna put like more of it on the patient.
They're
Or they
gonna,
won't
right,
pay you
they're
for
gonna
Please
treatment.
do it because I can't figure it out. I'm sorry.
okay. It's gonna be a lower rate, right?
Mhm.
So if they are readmitted within 30 days of discharge, okay, especially for the same problem, right? There is a chance that that hospital is going to get a reduced payment. Um, but what about not just the readmission though? What about the other issues? What did he say about his medications?
He can't afford to pay for.
Right. So he's having trouble paying for his medications, right? So what does that mean, right? Where he said he's skipping doses.
Mm-hmm.
Hmm.
He's got hypertension, he's got diabetes, he has chronic kidney disease, stage 3, right? And so if he's not able to take his medications, right, he's going to continue to have exacerbations of his chronic illnesses. So, what are some things that we can do as nurses that can help to improve safety and quality of care for our patient?
Like connecting him with a caseworker, a social worker, so he can get maybe like affordable medication,
Very
so
good.
he
Yeah.
isn't having like rebound, like hypertension and having to keep coming back and forth.
Very good. Yes. Get him a caseworker, a social worker, right? So, what are some of those community resources, right, that are available to him? So for one, maybe we can find him some like prescription discount plans, or, maybe there's other things out there that can help him pay for his medications. What else for safety and quality of care can we look at?
Mm. Like when he's ambulating, trying to move by himself, and he's already short of breath, just making sure he knows that, like, hey, use the little bell so somebody can help you to the restroom.
Mm-hmm. So while he's in the hospital, right, we're going to implement those safety precautions, right, so that, he uses his call bell, or somebody has suggested, good one should I'm in, right? Maybe someone can do home visits, right? Help
Mm-hmm.
him. Um, he may not qualify for home health. He may qualify for home health. It really just depends. However, okay. Um, maybe if he belongs to a church, right? Maybe there's some volunteers within his church that can come out and, like a parish nurse or somebody, or even volunteers, right, that can come and help do some checks on him. Um, I forgot what I was gonna say. Like things like Meals on Wheels are an option too, right? Meals
Mhm.
on Wheels, or it doesn't say anything about family, so not sure if there's family around, but family may be able to assist as well. There was something else I wanted to say, and I can't remember. It'll come to me. But which of those findings require immediate reporting to the RN or the healthcare provider?
The
Think
shortness
AB,
of breath.
right? Always think your ABCs. Yep. That cough frequently and appears more short of breath. So there's a couple of different things, right, that can play a part in this, right? For one, I don't remember. I'm going to go back to this slide. It just says he was admitted with a community acquired pneumonia. It doesn't say, right, how long
By
he was
his power that
there.
is working in us. Do you ever notice how when you're asking God to do something in your life, you sometimes get these convictions, like your spirit?
I don't, yeah. Was that you, Kizzy? Or somebody's listening to it? Sounds like a devotional. Um, don't know how long he's been on the antibiotic, right? If he's coughing more, if he's more short of breath, is that antibiotic effective, right? What's going on with him respiratory wise? I'm going to go back to what are some other interventions that could potentially help him? Well, actually, you know what? Hold that thought. We're going to move forward. So the factors that can contribute to the cost of healthcare, right? We talked about readmissions, right? It's going to increase the cost of healthcare. Medication noncompliance, right? We already talked about that, how it can worsen those chronic conditions. Um, and some of those preventable complications that increase length of stay and expenses, right? If he is getting up unassisted and he falls, right, or falls and breaks a hip or something along those lines, right, that's going to increase his length of stay. It's also going to increase those healthcare costs. And then I'm sorry, don't remember, but yes, the social worker, right? Because if we get proper discharge planning, that can help to reduce future hospitalizations because that social worker or that case manager that, these chronic diseases can be managed, right, by a primary care physician. Maybe he doesn't have a primary care physician. Maybe he needs a primary care physician to help him manage, right, these chronic conditions. And if he's seeing a primary care physician, right, they're going to be able to recognize, oh, you're getting sick or something else is happening so that we can try to, right, prevent some of those readmissions or those even prevent future hospitalizations. So we look at quality care. We've already talked about them, right? The medication, the education, infection. This is a big one, interdisciplinary communication. What members of the IDT could your patient here benefit from?
Social worker,
Okay, social worker. Yep.
dietary probably,
Okay, dietary.
Nursing
cardi
staff.
cardiologist.
Okay, a cardiologist. Yep. Respiratory therapist. Yep, that was a good one too. Who else? He's a fall risk. So
OT,
OT and
physical
Physical
therapy.
therapy.
okay. What's the difference between PT and OT?
Physical therapy help you with your range of motion, so to say. OT
Functional is
is
for
more of a
ADLs.
yeah, everyday kind of thing, help you with
every
your
day.
routine in your home.
Right, exactly. So physical therapy can help with range of motion, muscle strengthening, right? So if we can strengthen some of those core muscles, right, that may decrease his fall risk a little bit. And then OT can help with his ADLs, right? So bathing, um, you know, laundry, cooking, cleaning, getting dressed, right? Lots of different things that they can help with, right? So we may need to bring those services in. And then, of course, respiratory therapy, right? Maybe we can, of course, we want to use the incentive spirometer, but maybe he needs some like some breathing treatments, even some, postural drainage or I forgot what I was oh my gosh. Um why can't I think of it? When you're banging on their chest. Chest physiotherapy. Oh my gosh. Right. So variety of different services that respiratory therapy can offer. I don't know why I couldn't think of it. We talked about the safety issues, right? We talked about him being a fall risk, medication administration without barcode scanning, right? We know how important documentation is. So what's the issue here if we don't have the barcode scanner? What's the issue with that medication? How do we get
Like you
it
can't
into the
really like account for it within the system as well as just having extra verification.
exactly? So think about this. Let's say it's getting ready to be lunchtime, okay? So you've already given him his medications. Excuse me. The barcode scanner has been plugged in, it's charged, or it got a new battery. And you tell your coworker, hey, I'm going on my lunch break. Here's my 4 patients. You give a report. And you don't mention the medications for whatever reason. I'm just going to say that you don't mention the medications. And so this nurse now is taking over your 4 patients while you're on break and notices that his hypertensive medication isn't documented, right? It shows that it's not been given. And what happens if she goes in and says, oh, I'm going to do her a favor. She's been really busy today. I'm going to give her medicine, give him his medicine, right? So now he potentially gets a second dose of medication, right? So most places now will be, to hopefully they have some sort of a paper documentation trail that you can use in the event, right, that the systems go down or something isn't working. But these are things that have to be addressed. And absolutely, the dose could have changed, right? There's so many different variables that can go into that. Um, Infection transmission, short staffing, that unlabeled IV tubing, I'm telling you, that drives me nuts. Okay. Um, you would have to follow your facility policy for this, but I will tell you, for me, when I go in and I see IV tubing that's unlabeled, guess where it goes? Goes in the trash can, and I'm gonna get a fresh IV tube, or a fresh IV tubing to hang for my patient. So some of the things that as the LPN should do, reinforce those fall precautions, right? Making sure he knows where his call bell is. He's in the hospital, so you can do bed alarms, right? But you want to remind, hey, here's your call bell. If you need to get up to use the restroom, right? We want you to push this button. We could even offer him a urinal, right? If he's continent and he, is worried about getting up to use the bathroom, we can offer him a urinal, right? So he can use that at the bedside. You want to make sure that RN knows about those worsening respiratory symptoms. You want to make sure that dietary knows about that diabetic diet so they don't send a regular tray again. Make sure you follow your rights of medication administration. We're going to provide education to our client regarding medication adherence, okay? But if we don't put the other resources into effect, like the social worker and some of those community resources, giving him the education about medication adherence and compliance is not going to be effective if he's not going to be able to pay for them, right? So again, those community resources are going to be really important. We're gonna report the equipment malfunction, right? So why is, why did the battery die on the scanner? What's going on with it? And then always use your S bar. All right. So question number 1 here. Which factors contribute to increased healthcare costs? So select all that apply. So we have hospital readmissions, medication noncompliance, early discharge teaching, preventable falls, infection prevention. Which ones are those which one of those can contribute to increased healthcare costs?
A and B.
A and B.
A and B. All right, let's see. Da-da-da. Preventable falls. Okay. Now, not all falls are preventable. We know that, but we need to make sure that all of our fall precautions are put into place, right? All right. Which nursing action promotes client safety? Skipping medication scanning during busy shifts, delegating oxygen assessment to unlicensed personnel, following fall precautions consistently, or ignoring unlabeled IV tubing until the next shift.
C.
C.
Absolutely. Following those fall precautions consistently, right? All right. The LPN understands quality improvement when stating A, quality care focuses or only focuses on client satisfaction. B, safety and prevention reduce complications. C, costs are more important than outcomes. Or D, staff shortages do not affect care quality. Which
B.
one shows?
B.
B.
E.
Yep, very good. B. All right, talked about this already, but which action by the LPN is the priority?
C.
D.
Yep, absolutely. Assess the client's worsening shortness of breath. All right, you guys did awesome. Good job. And so this week I went into the Saunders book, and I chose, I'm going to go back. I'm going to start over again. So the topics that I have chosen, as soon as I find them again, are going to be delegating and supervising, ethical and legal, management of care, prioritizing, and quality improvement. And so there's, oops. Let's try that again. I hit the wrong button. There are a total of, I think it's 138 questions, but I used some earlier today in my other class. So we've got 127 questions left. We're not going to get through all 127, but those were the topics that I picked. So just to give you an idea. And so you can do this either way. You can answer out loud, or you can put the answer in the chat. Either way is acceptable. And I'm going to try to untie my tongue for some reason. All right. So here we go. All right. So the nurse is assisting in reviewing the critical paths of the clients on the nursing unit in performing a variance analysis. And I'm not sure if you guys are going to know this one, but in performing a variance analysis, which data would indicate a negative variance? Okay, so number one is normal vital signs in a post-op craniotomy client. Number two is signs of wound healing in a post-op abdominal incision. Number three, the presence of dysrhythmias in a client with a myocardial infarction. Or four, a client demonstrating accurate insulin administration following teaching. So,
Three.
okay, got a whole bunch of threes. I was just going to ask, what's a negative variance?
The opposite outcome, like what's not supposed to be happening.
All right. So, very good. Yes. So we look at the rationale. Variances are actual deviations or detours from the critical paths. They can be positive or negative, avoidable or unavoidable, and can be caused by a variety of things. Positive variance occurs when the client achieves maximum benefit and is discharged earlier than anticipated. Negative variance occurs when untoward events prevent a timely discharge. Variance analysis occurs continually, in order to anticipate and recognize negative variance early so appropriate action can be taken. Very good. All right. The nurse is attending an agency orientation regarding the nursing model of practice implemented in the facility. The nurse is told the nursing model is a team nursing approach. What does the nurse determine is a characteristic of this type of nursing model practice? So one, a task approach method is used to provide care to clients. Two, a managed care concepts and tools are used in providing client care. Three, nursing personnel are led by an RN leader in providing care to a group of clients, or a single registered nurse is responsible for providing care to a group of clients. So we have a nursing model and we're using a team nursing approach. Trying to think what week I did talk about this, and I'm trying to think of what week it was. And
I think it's number 3.
Three. Yeah, it is three.
we got a bunch of threes. Let's see. Threes. All right, let's see. Very good. Yes, in team nursing, nursing personnel are led by an RN leader to provide care to a group of clients, right? So with team nursing, you'll have an RN, LPN, and a UAP. Okay, and each person is going to have their specific role. All right. The nurse is assigned to assist in working with food services in a poor rural school setting. A goal for the school dietary program is to avoid nutritional deficiencies and enhance the children's nutritional status through healthy dietary practices. In implementing interventions by levels of prevention, which primary prevention intervention would the nurse suggest? So one, case finding in the school to identify dietary practice. Two, school screening programs for early detection of children with poor eating habits. Three, conducting a community-wide dietary screening activity to detect community dietary trends. Or four, providing educational programs, literature, and posters to promote awareness of healthy eating. A good one. I like this question.
I would say providing education programs.
Okay. So how many levels of how many levels of prevention are there?
We have primary prevention, secondary, and
Tertiary.
tertiary.
Very good. Tertiary.
Mhm.
Okay. Tertiary, yeah. So we have primary, we have secondary, and we have tertiary. What are primary?
Primary is everything that we do to,
Like screenings,
I think screening is a secondary.
secondary.
The primary, everything that we do to prevent.
Very good. So
Okay.
primary is prevention,
Okay.
secondary is screening,
Screening, and
tertiary
tertiary
is
is recuperation or something like that after the person.
Improving
treatment.
the quality of life of, yeah,
Yep.
of
So
the person
again,
Okay.
with the disease.
yeah, so just think of the first letter. So primary is prevention, secondary is screening, tertiary is treatment. That way you
Okay.
can, right? So you can keep
Yeah.
them. All
Good
right.
flow.
So we said what answer? I am so sorry.
4.
4. Okay. All right, let's see. Very good. Absolutely. So primary prevention interventions are those measures that keep illness, injury, or potential problems from occurring, right? Occurring. Oh my gosh. So again, primary prevention. Good job. All right. The nurse is assisting in working with disaster relief after a tornado. The nurse's goal with the overall community is to prevent as much injury and death as possible from the uncontrollable event. Finding safe housing for survivors, providing support to families, organizing counseling sessions, and securing physical care when needed are examples of which type of prevention. So we have primary, secondary, tertiary, or aggregate. So we're finding safe housing for survivors, support to families, counseling sessions, physical care. What level of prevention is that?
Tertiary.
Tertiary.
2.
Yeah.
Tertiary. I know it doesn't, and for some reason, just like looking at it, it's like looks hard to say. So tertiary prevention involves a reduction of the amount and degree of disability, injury, and damage following a crisis. Very good. You guys are awesome. All right. The nurse is assisting in planning client assignments. Which is the most appropriate assignment for an unlicensed assistive personnel? So 1, caring for a client with a new colostomy. 2, caring for a client with newly diagnosed with diabetes. 3, assisting a client to ambulate after an appendectomy. Or 4, assisting a client to perform a self-dressing change on a wound before discharge.
4.
All right, so I got a couple 3s. I got a
4.
4.
Say 3.
All right, I got a couple more 3s, couple 4s. Never 3. All right, I'm going to go with 3 because that's the majority. Very good. Yes. So the nurse must determine the most appropriate assignment based on the skills of the staff member and the needs of the client. In this case, the most appropriate assignment for a UAP would be to assist a client to ambulate after an appendectomy. Okay, 1, 2, and 4 would require assessment and teaching, so they can't be delegated, right? So caring for a client with a new colostomy, right? We need to assess the colostomy, or the ostomy site, right? We may need to do patient teaching, same thing with our diabetics, and assisting a client to perform a self-dressing change on a wound before discharge, right? That nurse needs to go in there and watch that to make sure, right, that he is doing it appropriately. So when he gets discharged, right, he knows how to care for that wound at home. All right. The nurse is assigned to care for 4 clients. In planning client rounds, which client would the nurse collect data on first? So 1, a client scheduled for an x-ray. 2, a client requiring daily dressing changes. 3, a post-op client preparing for discharge. Or 4, a client receiving oxygen via nasal cannula who had difficulty breathing during the previous shift.
4.
That one was that was a giveaway, right? So yes, absolutely. Airway and breathing are always a high priority, and the nurse would attend to the client who had been experiencing a breathing problem first. Very, very good. All right. The nurse is planning the client assignments for the shift. Which client would the nurse assign to the unlicensed assistant personnel? 1, a client requiring twice weekly dry dressing changes. 2, a client requiring frequent ambulation with a walker. 3, a client on bowel management program requiring rectal suppositories and a daily enema. Or 4, a client with diabetes mellitus requiring daily insulin and reinforcement of dietary measures.
2.
1.
All right, majority rules, we got 2. So yes. So assignment of tasks needs to be implemented based on the job description of the UAP, the level of the level of clinical competence in state law. So 1, 3, and 4 involve care that requires the skill of a licensed nurse. Although the UAP may be trained to administer an enema, depending on the State Nurse Practice Act and policy, a rectal suppository needs to be administered by a licensed nurse. So option 2 is the most appropriate assignment for that UAP. All right. A student nurse has received the client assignment for the day and is organizing the required task. The nursing instructor reviews the plan for time management with the student and determines that the student needs assistance with the plan. If the student indicated that which activity would be part of it. 1, providing time for unexpected tasks. 2, prioritizing client needs and daily tasks. 3, gathering supplies before beginning a task. Or 4, documenting task completion at the end of the day. So which one which of those determines that the student needs assistance with the plan if they indicated that which activity would be part of it?
The ones that shows that she needs assistance, I think is number 1.
All right, I got a
Or
1,
maybe,
I got a couple 1s, and I got a 4.
maybe I'm reading the question wrong.
I know I had to read it twice. Got a couple 4s and a couple 1s. All right, I'm going to go with majority. Let's see. There you go. The nurse would document task completion continually throughout the day. Okay, so that was the key right there at the end of the day, right? We're not going to go all day and then sit down at the end of the day and do all our documentation, right? We're supposed to document on our patients, right, continuously throughout the day. All right. The nurse is giving a bed bath to an assigned client. A UAP enters the client's room and tells the nurse that another assigned client is in pain and needs pain medication. Which action would the nurse take? So 1, finish the bed bath and then administer the pain medication to the other client. 2, ask the UAP to find out when the last pain medication was given to the client. 3, ask the UAP to tell the client in pain that medication will be administered as soon as the bed bath is complete. Or 4, cover the client, raise the side rails, tell the client you'll return shortly, and administer the pain medication to the other client. I like this question.
4.
4.
All right, everybody is in agreement here. Very good. Yes. The nurse is responsible for the care provided to the assigned clients. The appropriate action is to provide safety to the client that is receiving the bed bath, prepare to administer the pain medications. And then don't forget that you were in the middle of a bed bath and go back after you give the pain medication. All right, a new nurse is employed at a local community hospital and is attending an orientation session. The nurse educator conducting the session asks the new nurse to describe an organization's mission statement. The new nurse appropriately responds with which statement? 1, it describes the benefits available to employees. 2, it outlines what the organization plans to accomplish. 3, it identifies the policy and procedures of the organization. Or 4, it defines the rules of the organization the employees must follow.
2.
Okay. 2 seems to be the common answer. All right. Very good. Yes. All organizations have a purpose or reason for existing. The purpose typically is expressed in the form of a mission statement. The mission statement outlines what the organization plans to accomplish. Some mission statements incorporate statements of philosophy or beliefs, purposes and goals, or objectives into a single statement. Other times, the philosophy, purpose, and goals are addressed in addition to the mission statement. These statements serve as benchmarks against which an organization's performance can be evaluated. All right. The nurse is newly employed in a health agency. The nurse is told that the decision-making process of the organization is based on a centralized structure. The nurse determines that this means the authority to make decisions is vested in whom? 1, each employee. 2, all members of the organization. 3, a few individuals such as the board of directors. Or 4, many individuals filtering down to the individual employee. Excuse me.
I would say 2.
Okay. So I got 2s, I got 1s, got a 3. All right, mostly 2s. All right. So a centralized structure in healthcare is, how do I explain it? So it's the decisions are more at the executive level rather than at the department level. So with regard to decision-making process, organizations can be described as having a centralized or decentralized structure. An organization is depicted as centralized when the authority to make decisions is vested in a few individuals. Conversely, when the decision-making process involves a number of individuals and filters down to the individual employee, the organization is said to operate in a decentralized fashion. Okay. So centralized means that we only have a few people making decisions. Decentralized means that it's distributed further, okay, down. And I think we've covered that one before, so that's all good. All right. The nurse is employed in a long-term care facility as a charge nurse of the night shift. The nurse determines that as a charge nurse, authority appropriately refers to which explanation. So 1, being responsible for what staff members do. 2, accepting the responsibility for the actions of others. 3, carrying the legal responsibility for the task performance or of others. Or the official power to approve an action, command an action, or see that a decision is enforced. This is a good question. So if you are a nurse and you are the charge nurse overnights, okay, how would you define authority or explain the authority?
I will say 4, but I'm not sure.
Okay. I
4.
think the majority here are saying 4. So let's see. Awesome. So authority refers to the official power an individual has to approve an action or command action or to see that a decision is enforced. And if you are alone on that overnight shift, right, you need to be able to have that authority. All right, so before we go on, let's take a break. Be back at 7:40. All right. You guys are doing awesome. All right. Next question. A nursing student asks a nursing student to describe accountability. Which statement by the student indicates an inaccurate description of accountability? 1, accountability can be delegated. 2, it carries legal implications for task performance. 3, one must answer for the care that one asks others to complete. Or 4, it refers to the process of answering or being responsible for what occurs. So again, a nursing instructor asks a nursing student to describe accountability. So we have 4. Seems to be the majority. And got some 1s, but for majority rules.
No.
So the correct answer is 1. Accountability refers to the process of answering or being responsible for what occurs and carries legal implications for task performance. Accountability cannot be delegated. One must answer for all the care given and for the care one asks others to complete. So remember, right, those 5 rules of delegation. When you are delegating a task to a UAP, right? You are still accountable, right? You are still responsible for those tasks being completed. All right. A nursing instructor asks a nursing student to describe the standards of care formulated by the American Nurses Association. Which statement by the nurse or by the student, indicates an inaccurate description of these statements? 1, they are specific guidelines. 2, they define professional practice. 3, they have some similarity to policy and procedures. And 4, they are authoritative statements that describe a common or acceptable level of client care or performance. Okay, so standard of care from the American Nurses Association. Which of those is an inaccurate description of the statements?
I would say 1.
Okay, I got a 1. I got a 3 and I got a 4. All right, I got another 3. I got a couple 3s. All right, we're going to go through. We're going to go with 3. That's the majority. So it is 1. Okay. So standards of care are authoritative statements that describe a common or acceptable level of client care or performance that have some similarity to policy and procedures. Thus, standards of care define professional practice. The American Nurses Association has formulated general standards and guidelines for nursing practice. They are broad and general in nature and apply across the nation. All right. The nurse discovers that one of their assigned clients is bleeding excessively from an abdominal incision. The nurse gives specific information or specific instructions to an unlicensed assisted personnel to attend to the other clients and tells another nurse to call the physician immediately. In this situation, the nurse is implementing which leadership style? Democratic, situational, autocratic, or laissez-faire?
Let's say 2.
Autocratic.
Yep. 3
Situational.
All right. So 3 seems to be the number of choice, and that is correct. Remember, with autocratic, that's directive leadership, involves the leader assuming complete control over the decisions and activities of the group. In this situation, the nurse assumed the autocratic style of leadership, so all necessary tasks would be accomplished immediately. Democratic leadership, also called participative leadership, is characterized by a sense of equality among the leader and other participants. Situational leadership is a comprehensive approach that incorporates, gotta go down, the leader's style, the maturity of the work group, and the situation at hand. Laissez-faire leadership style is a permissive style of leadership in which the leader gives up control and delegates all decision-making to the work group. All right. The nurse is caring for a client with a diagnosis of end-stage renal disease. The client tells the nurse that a lawyer has prepared a living will and will be visiting the client today so that the will can be reviewed. The client also tells the nurse that the lawyer has asked for a witness to sign the will and requests that the nurse act as a witness, which is the most appropriate nursing response to the client. 1, I would be pleased to do that for you. 2, you need to talk to the nursing supervisor. 3, I never sign anything and I need to refuse to do this too. Or 4, a nurse caring for a client cannot serve as a witness to a living will. All right, I got a couple 4s and a 2. Need some.
Four.
Another 4. All right. Correct. Living wills address the withdrawal or withholding of life-sustaining interventions that unnaturally prolong life. It identifies the person who will make care decisions if the client is unable to take action. It is witnessed and signed by 2 people who are unrelated to the client. Nurses or employees of a facility in which the client is receiving care and beneficiaries of the client must not serve as witnesses. All right. So a client with COPD asked the nurse for assistance with preparing a living will. The client tells the nurse that they have not discussed the living will with the family and wanted to make some decisions before discussing the will with the family. Which initial step in preparing this document would the nurse inform the client to do? 1, talk to the family. 2, contact a lawyer. 3, consult with the American Lung Association. Or 4, discuss the request with the physician. It's a good one. What should we tell the client for setting up that living will?
The lawyer.
Number 2.
Okay, I got a 2.
Would it be 1?
Got a 1. Well, he says he hasn't, what does it say? They haven't discussed the living will with the family and wanted to make decisions before discussing with the family. So he doesn't want to talk to the family.
Okay.
So
Legal counsel would be the most.
So I got 2 and I got 2 2s and 2 4s. So I need some tiebreakers.
Maybe 4.
Okay, so I've got another 4. All right, we'll see. Let's see. Yep, talk to the doctor. So the client would discuss the request for a living will with the physician. The client would also discuss the desire with the family, although in this situation, based on client's feeling, talking to the family would be the second step. Will should be prepared with legal counsel and would identify an executor, geez, of the estate and address distribution and use of property and specific plans for burial. Although option one may be helpful, this contact would not be the initial step. The lawyer would be contacted following discussion with the physician and the family. So we're going to talk to the physician first, then he can talk to his family, then he can contact the lawyer. All right, a client with metastatic bladder cancer is admitted to the hospital for chemotherapy. During data collection, the client tells the nurse that a living will was prepared 2 years ago and asks the nurse if this document is still effective. What is the most appropriate nursing response? One, living wills may only be valid for 6 months. You will have to discuss the issue with your lawyer. Since your condition has changed, you will need to make a new living will and file it with the state. Or, yes, it is effective, but you may want to discuss any changes you desire with your physician.
No, I'm confused with this one.
Okay, that's okay. So what is a living will? Let's start there.
It's it's a document that you prepare that is a directive, like what you want to do with your with whatever happens to you when you are a medical condition, with your properties, with financials, with um so he already have it on place.
Right. So a living will, it says, like, this is what I want to happen, right? And when do we make a living will?
We can make it at any point. Most of the people do it when something happens, when they have a medical condition that they,
But
I don't
once
know.
you make it, it's always effective, right? Until you decline
Yes,
it.
Yeah,
it's effective until you change it. But in this case,
So maybe it's 4.
right. So a living will is a legal document. It tells people this is what I want done in the event I become terminally ill or permanently unconscious, can't communicate, whatever the issue is, okay? And it's something that normally we do when we're well, right? We can obviously, in certain cases, if we do get, a terminal diagnosis, we can set up like what we want done and what we don't want done. Um, and yes, it is 100%. It doesn't expire unless the patient says, I don't want this anymore. I want to redo it or whatever it is. So yes, clients often change their minds about desired treatments as their disease state progresses. Therefore, it's important to reassess a client's living will. Under the Natural Death Acts, an individual can tell the physician exactly what treatment is or is not desired. Living wills do not expire in 6 months. Verbal directives may be given to physicians with specific instructions in the presence of 2 witnesses. Attorneys and notaries may not be required. Each state has its own unique requirements, but the living will does not need to be filed with the state. All right. The nurse is caring for a client who is receiving IM antibiotics. The nurse enters the client's room to administer the prescribed antibiotic, and the client tells the nurse that the medication burns and that they do not want the medication to be given. The nurse tells the client that the medication is necessary and administers the medication. Which crime can the client legally charge the nurse as a result of the nursing action? Is that assault? Is it battery? Is it negligence? Or is it invasion of privacy? Everybody's got this one.
It's assault.
What's the difference between assault and battery?
I meant battery, sorry.
Assault is the threat and battery is the actual
Yep, assault's the
threatening to
threat,
kill.
battery is the
Yeah.
okay. Yep, an assault occurs when a person puts another person in fear of a harmful or offensive contact. For this intentional tort to be actionable, the victim must be aware of the threat or of harmful or offensive contact. Battery is the actual contact with one's body, and then negligence involves actions below the standard of care. An invasion of privacy occurs when the individual's private affairs are unreasonably intruded. All right, good job. Yep. All right. I had my husband, he always gets them mixed up too. And I'm like, I keep trying to explain it to him and he doesn't want to get them straight. All right. The nurse overhears a client ask the physician if the results of a biopsy indicated cancer. The physician tells the client that the results have not returned, when in fact the physician is aware that the results of the biopsy indicated the presence of malignancy. The nurse is upset that the physician has not shared the results with the client and tells another nurse that the physician has lied to the client and that this physician probably lies to all of the clients. Which legal tort has the nurse violated by this statement? Libel, slander, assault, or negligence? And this is another one. All right, got a bunch of twos, so we're going to go at two. Very good. Yes. So defamation takes place when something untrue is said, which is slander, or written, which is libel, about a person, resulting in injury to that person's good name and reputation. And we've already talked about assault. We've talked about negligence. So yes. So slander is said, libel is written. All right. The nurse is preparing to administer medications to an assigned client and notes that the prescription for furosemide is higher than the recommended dosage. The nurse calls the physician to clarify the prescription and asks the physician to prescribe a dosage within the recommended range. The physician refuses to change the prescription and instructs the nurse to administer the doses prescribed. What action should the nurse take? So 1, discontinue the prescription. 2, contact the nursing supervisor. 3, administer the dose as prescribed. Or 4, call the state medical board and report the physician. All right, everybody's got 2. Absolutely, yes. So if the physician writes a prescription that requires clarification, the nurse's responsibility is to contact the physician for clarification. So that was absolutely correct, right? If there's no resolution regarding the prescription because the prescription remains as it was written after talking with the physician, or because the physician cannot be located, the nurse would then contact the nurse manager or supervisor for further clarification as to what the next steps should be. Under no circumstances would the nurse proceed to carry out the prescription until clarification is obtained. All right. The new nurse graduate asks another nurse about the need to obtain professional liability insurance. What is the most appropriate response by the nurse? 1, the hospital insurance covers your actions. 2, nurses need to have their own malpractice insurance. 3, it is very expensive and you really don't need it because the hospital covers you. Or 4, the lawsuits are filed against primary healthcare providers in the hospital, so you are safe not to obtain it.
Always
All right.
safe too.
2 is the majority here. So absolutely. Number 2, nurses need to have their own malpractice insurance. Nurses need their own liability insurance for protection against malpractice lawsuits. Nurses erroneously assume that they are protected by an agency's professional liability policies. Usually when a nurse is sued, the employer is also sued for the nurse's actions or inactions. Even though this is the norm, nurses are encouraged to have their own malpractice insurance. It's not, I mean, it's not super expensive either. All right. The nurse witnesses an accident in which the victim was hit by a car. The nurse stops at the scene of the accident and administers safe care to a victim who sustained a compound fracture of the femur. The victim is hospitalized and later develops sepsis as a result of the fractured femur. The victim files suit against the nurse who provided care at the scene of the accident, which accurately describes the nurse's immunity from this suit. One, the Good Samaritan laws will not protect the nurse. Two, the Good Samaritan laws protect laypersons and not professional healthcare providers. Three, the Good Samaritan laws will protect the nurse if the care given at the scene was not willfully negligent. Or four, the Good Samaritan laws will not provide immunity from suit if the nurse accepted compensation for the care provided.
Three.
So we got twos and threes. All right, so we'll go with three. All right, correct. Absolutely. So your Good Samaritan laws are passed by state legislatures to encourage nurses and other healthcare providers to provide care to a person when an accident, emergency, or injury occurs without fear of being sued for the care provided. It is called immunity from suit. This protection usually applies only if all of the conditions of the law are met, such as the healthcare provider receives no compensation for the care provided and the care given is not willfully and wantonly negligent. Good job. All right. An adult client is brought to the emergency department by ambulance after being struck by a car. The client is unconscious and he is in shock, doesn't say he. A perforated spleen is suspected and emergency surgery is required immediately to save the client's life. No family members are present. In regard to informed consent for the surgical procedure, the nurse plans to take which best nursing action? One, ask the hospital chaplain to sign the consent form. Two, transport the client to the OR immediately. Three, call the nursing supervisor to initiate a court order for the surgical procedure. Or four, call a family member to obtain telephone consent before the surgical procedure. I like this question.
I think four.
Okay. I've got a couple different. I got two, I got one, I got four. Let's see what else I got. Well, I got lots of twos and I got a couple fours. So
I'm
right
between
now,
3 and 4.
all right, right now, two has got the majority vote. So I'm going to go with two. So yes. And it's an adult client. Okay. So generally in only two instances is the informed consent of an adult client not needed. One instance is during an emergency in which delaying treatment for the purpose of obtaining informed consent would result in injury or death to the client. The second instance is when the client waives the right to give informed consent. So that was the key here. It was an adult client. What if it was a pediatric client?
Under 8.
Wouldn't you have to stabilize the child
You have to
or
get
something like
parental
that?
consent.
Yeah, until you can get or if they was accompanied by like a caregiver who was in charge at the time or something like that. I remember it being a question.
Right. So in this situation, let's say it was a child that got hit by a car. Okay, maybe they I don't know, maybe I'm trying to think of something random because usually kids are going to be by an adult. But let's say it was a 14-year-old and he was walking home from school, right? And got hit by a car and the ambulance brought him in and maybe mom and dad weren't home, right? Nobody was there. So in that situation, we would try to now, even with the pediatric patient, we will try to get consent, okay? we'll try to call a family, we'll try to call mom, we'll try to call dad. We can have two nurses witness, right? That, hey, yeah, it's okay. But still, we're still going to provide care, right? Especially when it's life or limb. All right. We're still going to provide care. We'll get consent later. All right. The nurse manager asked an LPN to work on their day off because of a short staffing problem. The licensed practical nurse has already made plans and does not want to work on the day scheduled to be off. Which response by the licensed practical nurse to the nurse manager is assertive? So one, I can't work that day. Two, you know how I hate to work extra shifts. Three, I will if you need me, but I might be a few minutes late. Four, I have planned to take the day off and will not be able to work on that day. Which one of those is assertive?
Mm.
All right, we're going to go with four. So yes, it is four. So remember assertive. The most assertive response is the one that is direct and conveys a clear message in a positive manner. Option one is passive. Option two is aggressive. And then option three is passive aggressive, right? I'll work, but I'm gonna be late. So yeah. The most correct is I plan to take the day off and will not be able to work on that day. All right. An unlicensed assisted personnel who has been employed in a long-term care facility for 8 weeks is consistently 10 to 20 minutes late for work. The UAP's lateness has caused unrest with other staff members in the nursing unit. The UAP is due to receive a 3-month probation evaluation in 1 month. Which is the most appropriate action by the nurse in charge of the nursing unit when dealing with this situation? So one, telling the other staff members to cover for the UAP until she arrives. Two, telling the UAP that they will be fired if the behavior does not change. Three, addressing the lateness with the UAP at the 3-month probation evaluation. Or four, confronting the UAP to discuss the lateness and initiate problem-solving measures. Which of those is the most appropriate by the charge nurse?
I would say four.
Four. Okay, we'll go with four. All right. So yes. So arriving late to work is unacceptable behavior, right? Although the UAP's behaviors cause unrest with other staff members, the primary concern is that this behavior affects client care. The nurse in charge needs to confront the UAP and discuss the lateness and initiate problem-solving measures that ensure that the behavior does not continue. It is inappropriate to wait a month to address the behavior. It is also inappropriate to expect other staff members to cover for the UAP until they arrive. In addition, this action will increase the unrest with the staff members. Telling the UAP, that they will be fired if the behavior does not change does not provide confrontation or address problem solving. However, firing may be an outcome if adequate warning has been issued and a change in behavior does not occur. All right, I think we have time for one more. All right, the nurse sees another nurse administer an incorrect medication to a client. The nurse who administered the incorrect medication does not report the error. Which would be the initial action by the nurse who observed the error? One, contact the supervisor to complete an incident report. Three, document the error in the client's record. Or four, ask the nurse if they intended to report the error. This is a good question.
Four, I think you asked before contact with the supervisor.
Okay, so we got fours and we got ones. Couple fours and a couple ones. Another one. Couple more fours. Hold on, I gotta count. Oh, let's see. We got one. Oops. We got one and then one, two, three ones. All right, we're three ones and three fours. I need a tiebreaker.
I would say one.
All right, we're gonna go with one. All right. So in this situation, the initial action by the nurse who observed the error would be okay to ask the nurse if they intended to report the error. To ensure, ouch, client safety, all errors need to be reported. The client also needs to be assessed immediately. An incident report needs to be completed by the nurse who administered the incorrect medication. The appropriate documentation also needs to be made in the client's medication record by the nurse who administered the incorrect medication. If the nurse who made the error indicates that the error will not be reported, then it may be necessary to contact the supervisor. All right. So, yes. So, ask them, hey, saw you give the wrong medication. Are you going to report that? And that's going to be the most appropriate response. And then, like it says, if they decided that, they say, hey, I'm not going to report it, like, not a big deal kind of situation, right? Then, then we're going to have to go to the nursing supervisor, right? Because who knows what the Medicaid means? Obviously, it's just a question, right? It doesn't say, what the medication is or, what's the issue. So we're gonna go ahead and just ask them first, and then we can always, go up the chain if we need to go up the chain. But good job. All right, guys, you guys did awesome. Any questions for me? You guys did great. Do you guys like doing the questions?
Yes.
Yeah.
Where can I find similar questions? Or what topic did you, um, how did you find those type questions?
So I use the Saunders and Kleck's book. But you also, I'll show you. Give me 1 second. If you go, I just gotta find it. Um, but I can show you where you can find similar questions.